think. Okay. Good afternoon, everyone. We are the Aspiring Congenital Heart Surgeons Association. My name is Ayush. I'm the Simulation and Surgical Skills Secretary. Along with me, we have a lot of the members of our committee, as well as our two great speakers, Professor Lotto, as well as Mr. Jones. So today we're starting off looking at an overview of a life in congenital cardiac surgery. Just so you can see here, we have our website for the society where you can go in, you can apply for a membership, as well as interact with us to see when our upcoming events are. So these are the members of our team. I'll let everyone just say hi and introduce themselves really quickly as well.
I'll go first. Hi, everyone. I'm Rishabh. I'm one of the FY2s currently. I'm hoping to be a cardiac surgeon. I'm the financial secretary of the association. Good to have you all here.
Hello, everyone. My name is Abdurrahman Azam. I've just finished my first year of medical school at Holyoke Medical School, and I am the events secretary.
Hello, everyone. My name is ACHSA Balaji. I'm the communication secretary, and I've just finished my first year at Holyoke Medical School as well. Nice to have you all here. Thank you.
Hi, my name is Mubasha, and I just finished finally and going into FY1, and I'm the Education and Mentorship Secretary at ACHSA. So, thanks so much, everyone, for joining.
And along with us, we also have Professor Lotto, who is one of our board of directors, who helped us found the society. Professor Lotto, if you'd like to just introduce yourself.
Thank you very much. I'm delighted to be here, actually, and I'm really looking forward to sharing with you our view on congenital cardiac surgery.
Thank you. And we also have a few more people who aren't able to join us today, but they will be present in future webinars as well. And Mr. Jones, who's been extremely supportive in getting this webinar off the ground as well, and who's been very supportive for trainees throughout. So if you'd like to introduce yourself and say a few words, that would be amazing.
Okay, good. Well, thank you very much. I'm delighted to be here and be part of this this society and presentation today. So I'm Tim Jones. I'm a congenital cardiac surgeon in the Children's Hospital. I'm also chair of the SAC, the Specialty Advisory Committee in Cardiothoracic Surgery that oversees training for all aspects of cardiothoracic surgery, including congenital cardiac surgery in the UK. Really keen to support everyone. I know it's a bewildering world out there when you're trying to look at training these days. And so the purpose of today is to hopefully give you some idea of what it's like to be a congenital cardiac surgeon and the challenges ahead of you, but also how to navigate the path that you'll need to go through the training pathway and be a point of contact. Myself and both Attilio, I think, would be happy to take any questions either after the webinar or at any time. Email either of us and we'll be able to see if we can help you.
Thank you so much. And I see a lot of people already interacting on the chat. So if you want to have any questions, do ask in the chat and we can put it through to both of our speakers. So just to reiterate, we do have some upcoming webinars as well, covering a range of different topics, including the fundamentals, going over the more basics, the morphology, anatomy, as well as echocardiography, and more featuring the training pathway as well. And then we're also going to dive into the operative techniques, the things that people want to see, and try to break things down to a fundamentals level so that we can make it useful for everyone. And we're also going to try and incorporate some fun talks about innovations in the specialty as well. And we also wanted to say we're planning some in-person events. Hopefully sometime this year we can get something off the ground and we'll invite everyone to come on board with us. And make sure you stay tuned to our website as well as all of our social media to keep updated, and become a member today while it's still free to join. So starting off, we have our first speaker, Mr. Jones, who will give us an overview of the specialty itself and the training pathway.
Okay, good. Thank you very much. Now look, I've been asked to do that, to sort of talk about an overview of the specialty, what the challenges are that we face as congenital cardiac surgeons, and then also some of the developments, and then moving on to training. So we're going to cover these areas: the specialty, developments in the specialty, the challenges for specialty and for individuals working in specialty, and then training pathways. And I've titled the talk, so you think you want to become a congenital cardiac surgeon. Hopefully this will stimulate more questions than it may raise answers. So look, what is cardiothoracic surgery? You all seem pretty well informed, but we've got to look at cardiothoracic surgery encompasses acquired cardiac surgery, thoracic surgery, and congenital cardiothoracic surgery. And obviously the acquired cardiac is ischemic heart disease, valve disease, aortic pathology. Thoracic, you can see the components of it there. And congenital we'll come on to now for the rest of this talk. What links all those three arms, because they're all the specialty of cardiothoracic surgery, is transplantation. We've got ongoing academia and research, which Professor Lotto will be talking about, and obviously education. That not only is the receiving of education, but also the delivery of education for subsequent generations and other specialty areas within the hospital and medicine. So, congenital cardiac surgery.
We're not able to see your slides at the moment.
Oh, we can't. Now, I've stayed the same as we are. So what's the problem? Should we do the same again then? Show taskbar. And then if we go on to that, we're still sharing. So let's have another go at presenting. Try that.
Yes, we can see it.
Yep. Okay. All right. Good. Thanks a lot. So you want to be a congenital cardiothoracic surgeon. We're going to go through the specialty, developments, challenges, and training. We mentioned here cardiothoracic surgery, three components. We've got cardiac surgery, which we tend to call acquired cardiac surgery, thoracic surgery, and congenital surgery. The acquired cardiac surgery to do with the management of ischemic heart disease, valve disease, and also aortic pathology. Thoracic, obviously we've got the four areas that encompass thoracic surgery, and then we have congenital, and we've got adult and pediatric. I'll come on to that in a bit more detail. And as I said, what links all these three areas is transplantation, academia, and education. What I'm going to do now really is go on to congenital cardiac surgery for the rest of this talk. It is the surgery for people who are born with a heart problem, not who've gone on to develop a heart problem later on. They were born with it, and they may be babies, infants, children, or adults. Now, cardiothoracic surgery in its whole is a very relatively young specialty. And in fact, Billroth back in the late 1800s came up with this great quote: any surgeon who would attempt an operation of the heart should lose the respect of his colleagues. And there probably are still many surgeons who feel the same about cardiothoracic surgeons, particularly cardiac surgeons, but we have moved on a bit. However, in the late 1800s, they thought they'd reached the pinnacle of surgery on the heart. And this is Stephen Paget, who's the son of James Paget, of Paget's disease. Surgery of the heart has probably reached the limit set by nature to all surgery. No method, new discovery can overcome the natural difficulties that attend a wound to the heart. So people in the early 1900s have pretty much given up a chance of operating on the heart. But the major developments are in the 50s with the heart-lung machine. We had the developments of arterial shunts to oxygenate blue babies, and also we had Walton-Lillehei in the cross circulation. But the big step forward was 1952, John Lewis and his team here, who closed an ASD, what we see as the most straightforward of all congenital operations. They closed this, first team to see inside a heart beating and recover it. A 5-year-old girl immersed in ice here, cooled to 27 degrees. They closed the hole with inflow occlusion, and then rapidly in under a minute, and then they rewarmed her in a bath, and she survived. It's fair to say that we all think of cardiac surgery or cardiothoracic surgery as the management of ischemic heart disease, but actually cardiac surgery came about for the treatment of congenital heart problems, initially being the management of ASDs, VSDs, and then went on to atrioventricular septal defects. So in the 1950s, there wasn't surgery for ischemic heart disease, and there were valvuloplasties done, but there were no valve replacements. It was all for the management of congenital heart disease. And what's happened over the years is, as we've got better at it, the age of our patients has come down. As the age of our patients has come down, the weight has come down. And coupled with that, the complexity, therefore, of what we can do has gone up. So here's Lewis and his team in the 1950s, and even up into the mid to late 60s, the operative mortality for closing an ASD, a hole in the heart, was up to 90% in hospital mortality. 9 out of 10 children didn't survive, and they're often in hospital for over a year. These days, we undertake all sorts of complex neonatal surgery without really thinking about it. And in fact, overall mortality now for all congenital cardiac surgical operations is less than 2%. It's currently sitting about 1.8%. So we've made major advances in congenital cardiothoracic surgery. As we've got better at doing it, our mortality has come down, and we used to monitor mortality as our outcome, but that's really a very blunt tool these days, particularly the mortality less than 2%. What we also know is that survival isn't the only thing that's important. If you're operating on a child, they have to be able to turn into a well-functioning and developed adult. And so we know as the mortalities come down, we're exposed to morbidity that we see in our patients. And as we get better at looking at the morbidity, such as neurological events, developmental delay, and associated problems like that, we're seeing that it might be a higher incidence than we think. And so we're currently directing a lot of our work and our research, and I'm sure Attilio will come on to this, really in improving the morbidity of our patients. So operating on babies, they will survive not only longer, but also have a better quality of life and a better function as adults. Of course, when we started doing cardiac surgery, these were the headlines. Patient and baby survives heart surgery. Nowadays, these are the headline. Patient or baby dies during heart surgery. And so there's been a huge change in the public expectation and pressure put on the surgical team. Many of you will be familiar with the Bristol inquiry, where up to approximately 170 children are thought to have died back in the 1980s into 1990s for surgical teams predominantly undertaking the arterial switch operation when they probably didn't have the necessary training and experience to undertake that surgery. That led to a major change in healthcare, and the NHS plan and the NHS which you'll all be working in its current format really underwent major developments as a result of the Bristol inquiry, and that's what brought in clinical governance. We still sit in the shadow of the Bristol inquiry in congenital cardiac surgery, but I'll come on the rest of the talk to explain how we've moved forward from that and how we now ensure that we deliver good and safe practice to our children. So how has this practice changed over the years? The biggest thing that people always tell me is, you're a congenital cardiac surgeon, you're going to be put out of work by the interventional cardiologists. Well, this graph here shows activity from the late 80s up until, this is quite old data now, 2011, where we're seeing an expansion of congenital procedures are being dealt with in the cath lab by the cardiologists. We can see here PDA occlusion, ASD closure, stenting of conduits and outlets. We can see VSD closure and embolization of collateral vessels. So yes, they are taking more of our workload. However, what's happened over that time is the workload's been replaced by more complex procedures. We've moved much more to primary neonatal repair. So operating on children for full corrective procedures in the first 1 month or at least year of life. We're seeing that single ventricle surgery has really expanded. And also, as our children are surviving now, we're seeing an increase in the amount of revision operations we're doing, upgrading tubes and conduits and valves and pathways as children get bigger. Plus, as we've developed our expertise, we can apply it to conditions that we couldn't previously treat before. And so we see all these operations have come in now as new operations. And this is really the area in which the likes of Professor Lotto and I work in, that this is our day-to-day activity on the more complex end of the surgery than certainly when we both trained. As a result of that, over 98% of the children we operate on now survive and survive into adulthood. And in the UK, just under 4,000 children undergo heart surgery every year. Now that has an interesting effect because before, children with complex heart disease didn't survive through childhood. Now 98% of them are surviving through childhood. And what this picture shows, this graph shows, is time along the bottom here, 2000 up to an estimated 2030. And we can see here the amount of children requiring congenital heart surgery in dark blue remains fairly static. But the amount of adult congenital heart disease, ACHD, is climbing, because every year we're putting 4,000 children into the adult clinics and the adult population with congenital heart, either operated or non-operated on congenital heart disease. And we predict that there will probably end up being, by 2030, 10% of the population walking around with congenital heart disease, either operated or unoperated. And now we've reached a tipping point where there are more adults with congenital heart disease alive in the UK than there are children. So a huge area of growth for us. And of course, the child who was born with hypoplastic left heart syndrome 25 years ago wouldn't really have been offered surgery in most centres. So we're only seeing those children coming into adulthood now in their years 18 to 2025. So they'd never been alive before, which is a very exciting time for us, because we've got a group of patients who we've got to learn as they learn and develop as well as to how to manage these circulations as we go through adulthood with them. So what sort of operations am I talking about? Well, the first time surgery, new recent diagnosis or conditions that have progressed in the adult population, or new surgical techniques come about. But the majority of our work in the adult section is based on the work that we performed in children. So we're upgrading tubes and conduits and dealing with the sequelae of the surgery they've had as a child, or else infection or failure of that surgery. Plus also transplantation. It hasn't really expanded in the way we thought it would because of problems with organ availability. But I think with mechanical circulatory support and potential increased organ availability, it will expand further. So that's really the sort of the background in which we're working in. Now, what are our environment and influences? And if you were to become a congenital cardiac surgeon, what are the things you're going to be working alongside? The big thing, and this is based on the back of the Bristol inquiry, is the monitoring publication of our results. We don't have to publish surgeon-specific results, but we publish centre-specific results, which the adult acquired surgeons who used to present surgeon-specific data, they now, like us, have moved to centre-specific data. So we work together very closely as a centre, and we're monitored on the overall outcome of the centre. We recognise there's a variety in risk that we undertake. From a closure of an ASD is a very straightforward thing, but if you're going to operate on a baby with hypoplastic left heart with a number of comorbidities, that's high risk. So we've got to risk stratify, and we're getting better at risk stratifying because of the research that you'll be hearing about being undertaken. The public expectations are very, very high. We've covered that, but we have to ensure there's good professional development, particularly for new generation of surgeons like yourselves coming through. And all these things you've got to recognize have an emotional and personal influence upon you as individuals. The other interesting thing is, in the past, it was see one, do one, teach one. We realize that's not the way to mentor and train our young generation of surgeons. And that's fantastic. Well, it's so good to be part of a session like this, because this is really what we've got to do, start mentoring and bringing on the next generation, which yourselves of congenital cardiac surgeons. I'm going to talk a little bit about mentoring and teamwork. But also we recognize there's an evolution now, even in congenital cardiac surgery, subspecialization, increasing amount of aortic work we're doing in adults, transplant we've mentioned already, and adult congenital heart surgery beginning to emerge as its own subspecialty. But those who are thinking of congenital cardiac surgery, this I think is the key point in this talk for me. It's a delicate balance between the courage to perform complex, risky surgery and the humility to question one's own ability on a daily basis. And as a successful congenital cardiac surgeon, you have to get that balance right. If you become too confident and too courageous, you'll run into trouble. But if you become too certain and too cautious, you won't be able to pursue the complex operations. You might become risk averse. And this is particularly so for the young consultant. If you become a consultant in adult cardiac or adult thoracic surgery, you're able to do all the standard operations. To become a consultant in congenital cardiac surgery is a bit like passing your driving test. You can drive the car, but actually you really need to start driving in order to learn and develop further. And we'd say that people who are appointed in congenital cardiac surgical roles as consultants, you're talking of another 3 to 5 years close mentorship to really reach full independence on a whole variety of procedures. Remembering that in adult cardiac surgery, there's coronary artery disease and there's surgery on the aortic, the mitral valves and the aorta, the tricuspid valve. But in congenital cardiac surgery, I think we recognize there's about 147 significantly different operations that we recognize to perform. And in fact, if you go into the subgroups of those operations, an even greater number. So it takes some time to learn them all. So how do we protect the trainee and the young consultant in congenital cardiac surgery? Because that puts a lot of people off. Well, it's about the working environment and the relationships within that working environment. We really have championed and I think led the way on multidisciplinary team working. So we meet a weekly meeting with our cardiologists, our anaesthetists, our intensive care doctors, and also all the allied healthcare professionals within the unit. We discuss every elective and urgent case, and there's a standardized format discussion, and we come to a consensus agreement. There is no one individual who takes that responsibility for the decision making. And this means that together we stand as a team. It also means that we can manage single waiting lists, and we can support and develop new consultants by allocating them appropriate levels of work as they progress through the development that they need. It's important for documentation. It supports the team and the individuals who are actually undertaking the surgery that there's acceptance. This is the way to go. It's important for governance and education. It's a very powerful educational tool, particularly as a trainee and also as a recently appointed consultant to be part of this meeting. And most importantly, it develops teamwork. We rely massively on teamwork to deliver things that we think our patients should deserve. The other thing that we've adopted, and I think we're beginning to lead the way on, is mentorship. And this is mentorship not only during your training, but throughout your career. And most of us now in our job plans that we work by in the NHS have mentoring periods allocated within that. All high-risk patients, I think in most units now, particularly if it's a high-risk patient who referred from another unit or high-risk patient there may be significant issues with, then we'd find 2 consultants would be operating together for those high-risk patients. And certainly in mentoring the newly appointed consultant during that 3 to 5, we would expect a senior surgeon stands opposite all recently appointed consultant surgeons to ensure they undergo the best training and personal and professional development. It's very good for governance. And actually, it's very enjoyable. Operating with your colleagues is great fun. And when you do a complex case, it can really take some of the stress and pressure off a complex case by having two sets of eyes and 2 brains and 2 minds trying to work out what's the best thing for our patient. And what we've been able to demonstrate is that with dual operating and mentoring, we can avoid the learning curve, because people always say, well, if I do congenital cardiac surgery, how am I going to know if I can progress? Well, you can see here overall that the 30-day mortality for the arterial switch has come down over time. But this is data we've taken from the Birmingham Children's Hospital. And you can see here with the new appointment of a consultant back in 2000, the mortality continued to decrease despite that consultant taking on a lot of that surgery under appropriate mentorship. And with a subsequent consultant appointed in 2005, again, no change in mortality. And in fact, the increasing profile in better outcomes continued through both those appointments. And that really shows you the effect that if you appropriately train and mentor people in the system that we have, you can avoid the learning curve. And here you see a development of that in a unit where you've got 4 surgeons, all appointed over different periods of time, all reaching the same outcome in the arterial switch operation. I really looked into this and published this on mentoring new surgeons. Can we avoid the learning curve? And from that, this is how we now base our training pathways, not only in trainees, but also in consultants in congenital cardiac surgery. Now, some of the challenges in this picture, there is actually a baby. Okay, the baby is over here. It's a pink towel, so it's probably a female baby, a young baby here, connected to advanced respiratory support, connected to an ECMO machine giving cardiorespiratory support, connecting to a dialysis machine giving renal support. So this is a baby in the first few days of life requiring all this level of treatment. And it raises the question and the ethical dilemma. We can always operate, but should we always operate? And this is one of the questions that we're facing more and more, because actually we've got to look at the long-term outcome for the child and the family. This data shows really the problem that we've got ourselves into by our own success throughout the specialty. Here you can see these rates in 20 days, 30 days, 40 days, and 50 days. This is 96 to 99, and these are subsequent eras. The length of stay is going up in the intensive care unit. That's because we're doing more complex operations on smaller babies, but it has a huge impact on resources, which are actually limited, as you all know, in a nationalised healthcare system. So we can keep babies alive longer. By keeping them alive longer, does it mean that they survive greater? Well, if they don't survive within the first 20 days, what we find a situation is that actually by prolonged intensive care, we don't change the overall outcome for the child. But of course, we're committed to that child and we're committed to that family. And so these are other ethical and moral dilemmas that we have about encompassing high-risk neonatal surgery. And these are things that you'll have to deal with on a day-to-day basis as a congenital cardiac surgeon. Now, the final part of the talk is really to come on to the training pathways. This picture shows two documents. The one on your left is the curriculum for cardiothoracic surgery. Overall cardiothoracic surgical curriculum is what we call our parent curriculum. And the curriculum on the right is the curriculum, which is the training manual, basically, for congenital cardiac surgery. Congenital cardiac surgery is a component of the overall parent surgical curriculum. So what I mean by that is that everyone, whether you want to do cardiac surgery, thoracic surgery, congenital surgery, transplant surgery, you have to follow the cardiothoracic surgical curriculum. You then later on go to subspecialize in congenital cardiac surgery, and I'll explain how that works. Here is our cardiothoracic curriculum, okay, divided into 3 phases, and it takes 7 years. So what happens is you finish medical school, you go off and you do your foundations, and then you can apply through nationalized selection for cardiothoracic surgery. Okay, this is the generality of cardiothoracic surgery. Success at national selection comes from submitting a portfolio of experience, and in that, we're looking for people who are demonstrating that they've got an application to a career in cardiothoracic surgery. And what I mean by that is you've spent time in hospitals, in cardiothoracic units, you've been involved in units, you've gone out of your way to try and understand what the specialty is all about. You'll have actually done some period of time in the operating room, you may have done some period of research or some higher study, obtained some higher degrees, may have done some presentations. Those are the sort of things that appear in the portfolio questions, and you have to enter your experience there. From that, you then will go through a national selection process, and now post-COVID, we've moved to an online selection process. And the successful people then are appointed to a national training number in cardiothoracic surgery. That's divided into 3 phases. Phase 1 is 3 years, which is ST1 to 3. In this phase, you will be in the generality of cardiothoracic surgery. Okay, upon completion and achievement of its competency-based curriculum, so upon achievement of various competencies at the end of phase 1, you will then be able to progress into phase 2, where you'll undertake further 2 years of training in either cardiac or thoracic plus general cardiothoracic emergencies. At the end of phase 1, you declare whether you want to follow a thoracic career or a cardiac career. And if you want to do congenital cardiac surgery, you'd obviously be following the cardiac career. So first phase, 3 years, generality, everyone goes into. We then get to this stage, decide you want to do cardiac or thoracic. You then go into phase 2. Thoracic trainees, it's more geared towards thoracic training, but they still have to cover cardiac emergencies, and vice versa. Cardiac trainees still have to cover thoracic emergencies. Then you go into phase 3 when you reach successful level of competencies here. And phase 3 is your higher level of training, and now purely in either cardiac surgery or thoracic surgery. That is the generality of what we call our parent curriculum. So where does congenital cardiac surgery fit into this? Well, just before we get on to that, you obviously have to take some examinations, and you do your MRCS in phase 1, and then your specialty examination or part 3 examination in phase 3 to demonstrate your knowledge equivalent to a day 1 consultant. If you want to do congenital cardiac surgery, it's very difficult to know whether that's what you want to do. And so what we've done is we've set up these 1 to 2 week tasters or observers in congenital and or a transplant unit. And so during phase 1, you can take 1 to 2 weeks and go to one of the recognized congenital cardiac surgical units in the UK. There may be one close to you in your region, or you may have one maybe where friends live or family live, and you can go there and spend 1 to 2 weeks in that unit as an observer, seeing what the day-to-day practice is like. If you think that that's something you really want to do, then you can do 6 months of training as either as part of your overall training program, or you can pause your training program to do 6 months of training so it doesn't impact anything else you might want to do in congenital cardiac surgery or maybe transplantation. So that's an opportunity there where you can really work as a doctor, as a surgeon, trainee surgeon in congenital cardiac surgery. If you decided that, yes, you wanted to do congenital cardiac surgery, you'd still carry on with your phase 1, phase 2 training. But then at the beginning of phase 3, you would apply for a 2-year national training program in congenital cardiac surgery. And this sits where your phase 3 training would be. So you've completed your general training, you've done some specialty training in cardiac surgery, and then you go into 2 years in the national training program in congenital cardiac surgery. And that is based 1 year at one centre and 1 year at another centre. And the 4 centres we use are Birmingham Children's Hospital, Alderhay, Newcastle and Great Ormond Street. Newcastle and Great Ormond Street both have transplant units and mechanical circulation support. Alderhay and Birmingham have mechanical circulation support but no transplantation. So you either spend a year in Birmingham or Alderhay and then the second year in GOS or Newcastle. You could, if you wanted to, instead do a transplant fellowship at that time. That runs around a similar time as well. I put that in to give you the full idea of what's going on. Now, this is an indicative time of 7 years. It takes most people longer than 7 years to achieve their training. You may be going through less than full-time training, which would obviously extend your period of training. You may have things called outcome 3s, which are when your training committee decide that you need maybe some further advanced training time in certain areas to reach your competencies at these levels, and that can extend your training program. You may do a period of research, which we'll hear about in the next talk. You may go and do a fellowship, either a fellowship abroad. You may want to do work in a centre abroad for 6 months to a year. You may do a fellowship in a different centre in the UK, and that could either be to replicate, to replace part of your time maybe here, or in addition, we can pause time. And we've got all these ways of pausing time on your training program called out-of-program experiences. You can see for out-of-program for experience, for training, for research, and out-of-program pause, which is what we can do here. We can pause your training program for you to go out of program to see if you want to do congenital cardiac surgery, spend 6 months, and then when you finish that, you come back into program and carry on. Or you can take an out-of-program pause for a career break if you just decide that you want to just really think things through and have some time out. If something, maybe you've experienced some major life event, we can pause the training program as well. So training programs, this is the backbone of it, and we can use the training program to get you to the end point, which is your certificate of completion of surgical training. Okay, so just to go through that, the phase 1, phase 2, congenital cardiac surgery comes in phase 3 through the national training program. If in the meantime you want to gain some experience, you can do a 1 to 2 week taster in any of the units, just an approach Attilio or myself for this. We can give you more information, or do a 6 month formal placement, either in a congenital unit in your region, or else you can go to a congenital unit in another region, either through having it accredited as part of your training, but most people choose to pause their training to do that 6 month period of time. And what do we do? Well, we go through these things called capabilities in practice. This is what I talk about, making sure you've got the competencies to manage an outpatient clinic, an emergency on call, ongoing care of inpatients, an operating list, and multidisciplinary team working. And in cardiothoracic surgery, we actually make sure that you're capable of looking to patients within the critical care area, the ICUs, and also you can assess surgical outcome at both a personal and unit level, because that's so key to what we're doing. And a lot of people say, oh, well, you're under extra scrutiny, extra spotlight in congenital cardiac surgery because your outcomes are so carefully monitored. Well, they are in all aspects of cardiothoracic surgery now, and they are increasingly and will become monitored in all aspects of surgery. The effectiveness and surgical outcomes are the priority moving forward in surgery and the development of safe surgery. And so don't feel that by pursuing a different surgical option, you'll avoid having to publish and disclose outcomes and be monitored on your outcomes, because it's going to come into all surgical specialties. We ensure you have the correct generic professional capabilities to have good practice, and these two things are key to the curriculum, the capabilities in practice and generic professional capabilities. So we will go through training in professional values, professional skills, knowledge, disease prevention, leadership and teamwork, safeguarding, particularly important in children, education training and research, as we'll be hearing about. The assessment process is multifactorial. We look at work-based placed assessments, we look at operative numbers, operative experience and competencies in the operating room. We get feedback from multi-source feedback from colleagues within the workplace. We get multi-consultant reporting from your trainer consultants to give feedback. Examinations, as you said, membership examination and also the subspecialty examination. And your AES, your assigned educational supervisor, will oversee your training, and every year you'll have to undergo a review of the competence to progress. That's the same whether you do cardiac surgery, thoracic surgery, or congenital surgery. It's the same structure throughout. So in summary, congenital cardiac surgery, hugely rewarding career. It's fair to say it's probably gives you the highest highs and the lowest lows, because it is challenging. It requires dedication, determination, and continued application throughout your career. It is technically, physically, and emotionally demanding, but also it gives you a tremendous return. It's a real privilege to do the job and interact with not just the patient in front of you, because remember, in pediatrics, you're treating the child and the wider family as well. And it's one of the few areas in medicine and surgery where you get to combine anatomy, physiology, morphology, cardiology, ITU, medicine and surgery. That's the thing that, well, I went into it because it was the thing that I wanted to. I liked intensive care medicine, I liked cardiology, and I wanted to be a surgeon. And I liked applied medicine. And actually, cardiothoracic surgery is the only surgical discipline where you can really pull in all those components into your working career. So that's a very brief fly through of where we currently are at, and also some of the career pathways. And I'm happy to take questions at any time now, or if in the future, please do email me, and we'll make sure my email's up on the website. So thank you very much indeed.
Thank you very much, Mr. Jones. We do have one question from the audience at the moment. Would you be happy to stay until the end to answer, or would you like to answer it now?
Absolutely. No, I can answer whenever.
Oh, perfect. Thank you. So we'll have Professor Lotto go ahead and present, and then we can take all the questions together, if that's okay.
Okay, I'll try to share my presentation. Can you see that?
Yes, we can.
Okay, so thank you very much, first of all, for the invitation. It's a great initiative what you are doing with the ACHSA, and I'm very pleased to be here. Now, I'm one of the consultants at Old Hay Children's Hospital in Liverpool, and I also have a part-time appointment at Liverpool John Moores University, which is not a medical school university. And I wanted to point that out actually because the academic career in congenital cardiac surgery is very, very difficult. And that's why I thought to give you an account of research for the aspiring congenital heart surgeon because I think actually it's important that you consider that possibility and how to continue to be involved in research. But the possibility to be a full professor in congenital cardiac surgery in the UK within a university, medical school university, it's very difficult. There was Professor Deleval at Great Ormond Street, and after him, actually, if I'm not wrong, the only full professor, which is a BHF, British Heart Foundation professor, is Massimo Caputo in Bristol. All the rest of us who want to be involved in research have got sort of appointment like mine, because the time doesn't allow anymore to be involved so much in research. But anyway, here we are. So in the next half an hour or so, I'm gonna tell you a little bit about how I got interested into research, and then why bother at different level, from medical student to trainees to junior consultant, because I suspect actually in this group of aspiring congenital heart surgeons, there are a heterogeneous group of people, and where to start, and give you a little bit of hints and tips of what I've learned through the years, and then as well, actually, I will present just to be a little bit more research focused, few of the projects that we had completed and that are underway in Old Hay, but giving an account really of the different types of research that can be done, and how to get involved at different level. So I graduated in '93 in Italy, in Milan, and the year after, actually, I was shafted by my my professor to become a research fellow at the National Research Council in Milan. And in reality, it was a great experience. I got involved into metabolism of the heart, and that gave me the possibility then to apply for a research fellow in Bristol under Professor Gianni Angelini, where I signed up for my MCH higher degree in 2002, and I continued that work, which gave me actually really the base for when I became a consultant to take on the position as a research lead for the group I was working in Leicester at that time. And once I moved, and in Leicester as well, actually, I continued to work with Professor Gavin Murphy on a couple of projects, especially pertaining on renal failure during ECMO, being Leicester one of the main ECMO player at that time, and probably it is still. And when I moved to Old Hay in 2015, I got contact with the Liverpool John Moore University, and the reason of that is because at that time there wasn't a cardiac professorship in Liverpool. So I'm talking about, when I'm talking cardiac, I'm talking really about the wide cardiac research, talking adult cardiology, adult cardiac surgery, let alone the congenital cardiac surgery. So there was very, very little. And I looked around, and I found actually that Liverpool John Moore University was offering me some networking with individuals that had the same aspiration as me, been involved in research in cardiac more than the University of Liverpool. And so far I've been a tutor for 4 PhD students in the last 10 years. 1 has finished and 3 are ongoing. And I've learned so much from them. And when I will present the research that we've been doing, is really credit to them more than to me, and what they've been doing and growing from a non-medical student, medical university, into really doctors of philosophy and taking up jobs around the country. So why bother doing research as a medical student? I think actually that, first of all, sometimes, as I've seen actually in some of you guys that I get to know the last few months, it's a personal aspiration. stimulate your intellect, and feed your inquisitive mind. And it's something that once that seed is being sown, actually, then it's going to stay there for all your career. And that inquisitive mind is what I think is very, very important. Asking yourself why something is happening, and not only to get on with it and accept what is being told. So as a medical student, it's not anymore a requirement to enter into training. But I would say actually that it looked good on your CV, and you will stand out. You will stand out a little bit later on in your career. Especially, it might actually get you to consider the possibility, as Mr. Jones, as the team was saying, to stop your career, to stop your training, to get more involved into research, and maybe want you to consider a higher degree. And if you are good at it, and if you are able to tailor a career as an academic trainee, there is a pathway for that, which is quite interesting actually. And when I was in Leicester, I was a training program director, and I helped one of the trainees to take on an academic training career, and it's quite interesting actually. So for the one of you that want to get interested in that, in research, then consider that, because we need people interested in that. So you also learn how to critically appraise papers, and and also become an expert on a particular topic that you get involved. It helps with networking, and this association is the typical example of how to networking in the right way. And you might like it. As I said, you might want to become a professor, the next Massimo Caputo, or the next Professor De Leval in the UK. It might also help, even though I said actually it's not anymore a requirement doing research to enter into a trainee job, but it might help, and you might stand out from the crowd of people who wanted to enter into the training job. Once I was told actually that if you are not seen, you do not exist. And that means if you don't publish, and if you don't go to meetings and present, you are no one. And that is probably even more if when you are a trainee and you are building up your career towards becoming a consultant. So during your trainee time, you still might like to continue to do research, and nowadays the training, it's done in regions, so you don't have anymore like in the old days, move from one unit to another. So you can stay in the region for a few years. You can actually just have a longer time project, and so on. It might help with your career progression, and also I found actually that it gives you an identity within the department. And give you actually that different people look at you in a different way, and I think actually it's important to stand out from the crowds. So where to start when you are a medical student, or you are a junior trainee, or even actually a junior consultant? You want to start to write something. I would say start easy and move more difficult later on. Start with some case reports, something that your consultant say, oh, I've never seen this before, and you will hear a lot in congenital cardiac surgery. So you can actually have a look at that, provide some nice imaging. You can write a case report, having published some of that. It's a good start. You boost your ego, and then actually you can move actually into review articles once you get interested in a particular type of case. You can write case series or review the literature, and then actually the natural progression is to start some retrospective studies, like follow-up cases, follow-up projects, case match control studies, and large database studies, and then actually move into prospective studies. Starting from pilot studies to randomized control trials, and we're gonna go a little bit more in details about those. And once you are an accomplished writer, then you are asked to write editorials, commentary to papers, and sometimes you can be involved in writing chapters for surgical books, which it's interesting as well. So how to learn to present a case or write a paper? So the first thing actually is really the literature search, and that is something that is not really well taught. And I always say, go to the librarian of your library, and he will teach you how to do it properly. And that is very, very important, because the way that I was doing in the old days was to put a very wide keywords, and came up actually with 1,000 papers, and then screen them actually quickly through the title, and that is not really the way. So librarians are there for that scope, to teach you how to do literature search. And then, as I said, starting if you have a good intracardiac images, or a good radiological images, write a case review. See how to write by reading some case reviews on the same topic. And even if actually the case has already been reported, it's always worth actually trying to report again, because if it's something it's rare, it could be actually interesting to have a few reports on the same interesting rare case. And so one thing that I always say to my registrars, if you want to write a paper, I found that learning how not to write a paper, it's a very, very good advice. And how to do that, it's signing up to be a reviewer for a journal. Now, they are open to everyone, and you don't need to be a reviewer for Nature or Science. You can sign up to be a reviewer for a small bulletin of the Royal College, and or low impact journals, and then you will be sent some papers that the first few you will be intimidated by that. Then you will learn actually really how not to write a paper, because I'm a reviewer of 3 or 4 journals, and some of them actually are really badly written, and it's embarrassing. So I still aim to review about 2 to 3 papers a month, and that gives me, and first of all, actually, it forced me to read papers and to be updated with the literature on a specific topic, and also give me the idea of what is happening in the field of that I'm interested in. So you can start, as I said, with a small bulletin, the Royal College Annals, and so on. And if your paper don't go through, don't get upset. Learn from the reviewers' comments. Most of the reviewers are really genuine reviewers that are interested in getting your paper published. And if it is rejected, just learn from their comments. But also seek support from your university tutors, from senior colleagues, and from people who have got actually within your department some idea of how to write a paper, and don't be shy for that. We are not born knowing how to write in scientific language. So there is always a way to start. There are plenty of general cardiac journals. There is the British Heart Journals, Cardiology, the European Journal of Cardiology, the JACC, Circulation, and more actually surgical orientated journals. There is a Journal of Thoracic and Cardiovascular Surgery, the Annals of Thoracic Surgery, and the European Journal of Cardiothoracic Surgery. These are the main ones. For congenital cardiac, they are a little bit more limited. There is a Cardiology in the Young, which is a good journal, and Pediatric Cardiology as well. And there is only one journal, which is the World Journal of Pediatric and Congenital Heart Surgery, which is fully dedicated. It's a bi-monthly publication, fully dedicated to pediatric and congenital heart surgery. And it's getting better and better, actually. And I would suggest if you have some nice, interesting case reports to submit to the World Journal. Is a very good one. So after you have started with some papers like that, case reports and of case series, then you want to get involved into retrospective studies. Now, retrospective studies, basically, it's to say we have implanted XY valve, or stents or whatever you want to count in a group of patients, and you want to follow up and see how these patients are doing, how many are still alive, or how the valve it's performing after 5, 10, 20, 30 years, whatever. So they're relatively fast to do, and they're not that difficult to write, because really, it's a matter of funding your data. But what you will need most than anything, you don't need a long ethic approval or lots of money, but what you will need a good statistician that gives you a help in going through your data set and organizing it in a way that you can then present the follow-up in a meaningful way. You need to be prepared to go through records and missing data and a lot of computer work to organize your data set. But, at the end, you might be able to present an abstract at the national meeting. And last year, as the Society of Cardiothoracic Surgeons annual meeting, we have very nice presentations by some of you in the audience section. And I was really impressed by the work that you guys are doing. And maybe, why not try internationally? And you might be able to go and present your work internationally, and maybe even publish the paper as a first author, which is obviously another aspect of boosting your ego and being able to show off a little bit within your department. Now, prospective studies are much more difficult. There is the work done by Nigel Drury of the group of Tim Jones, where they published actually a paper about this topic, about how difficult it is to be involved in prospective studies. What I have found actually that there is always the need before a big randomized trial or a big prospective studies or pilot studies, and they need less investment in terms of money, and but they're needed in order to present the case for the need for big prospective studies. But randomized controlled trials are difficult to run in congenital heart disease because of low recruitment. Parents are not that keen in, and they're going through stressful times at the time of you want to recruitment. There aren't many patients, and the group of patients that we treat are very heterogeneous. So to try to select an homogeneous group of patients, it's difficult. The ethical part of it is more complex because you are basically trying to recruit children into a prospective study. And I would suggest to get your PPI group, as your public and patients involvement group, very well defined, because they will give you a very good help in getting ethics through. And then the other difficulties is to get the fundings. There are organizations there. There is the British Heart Foundation, the NIHR, Heart UK, charities, and if you're linked with the university, you can access internal streams of funds. But obviously, competition is very, very fierceful there, actually, and also having to find the team actually that is going to work with you on a prospective study is difficult, because you will fight with the university or your local university or your local hospital for the research nurses, which are not many, are underfunded, and time, it's critical. Time that they can dedicate to that, it's critical. But they are the one that obviously you need to prospective studies take more time to get the results out, and so be prepared for a long journey. In practical steps, how do you you start? Basically, talk to your, if you are in a hospital, trust research department lead usually are very keen in give a help. Talk to the professor in your department and see and have a look, actually go prepared. So identify the players in your region and in your area, and find actually what the professors in your area are interested in, and go prepared and have a look actually what are the streams of research already in place. And also, as I have done with the Liverpool John Moore University, think laterally with the Department of Bioengineering, Department of Genetics and Imaging, Radiology. And as I learn, actually, don't be fussy. Non-medical school universities can offer very good people that want to collaborate with you, and offers a different point of view. And the last thing, actually, it might be worth actually thinking of investing how really to learn statistics well, something that I haven't done, and I found myself stuck at times with statistics, and I need to rely on someone else. And statisticians are really very, very, very scarce actually around. When I was at Birmingham Children's Hospital, they have a fantastic person in John Stickley that really helps the registrars, but not every department have got someone like that. He's a fantastic person, and it helps a lot of us taking our papers through. And I'm sure he's still around and he's still doing that. So the other thing to think of is that our specialty, it's a multidisciplinary specialty, and you have to use that to your advantage. So think about cardiology. Cardiology is made up of fetal cardiologists, electrophysiologists, interventional cardiologists, imaging. There are groups interested in heart failure, in transplantation, in ventricular assist device. So really think laterally. Don't just try to think about surgery. If you think about surgery, think about the fact that we treat neonates, you treat adult patients, so we treat a very large group of patients. So think about laterally. And again, actually think about the intensivists that might be doing some research in your area. ECMO, it's a very innovative tool, and a lot of research can be done, but as well as nutrition, renal replacement therapy, linked with the neonatologists that might want to see a specific group of patients that we treat that they might not see many. Think about anesthesia. There is a lot of work done about early recovery, early extubation, blood conservation, and even actually awake procedures nowadays. So think about that. If you want to know what are the topics actually that really bother parents, so to get some ideas, speak with the specialist nurses of your congenital heart department, because they usually are very good in directing you to a specific area. And consider also doing some work with the database with NICOR, International Registry, and the ACHSA database. Now, I will talk briefly about the ACHSA database later on, because it's a huge tool that at the moment I think is underused in the UK, but we can access that through different people that are into the ACHSA, which is the European Congenital Heart Surgery Association. So also speak with the professor, but consider one thing actually, that if you speak with the professor of cardiology or cardiac surgery, they usually have got their own ongoing projects, and they really don't have time, but they might be interested actually to add a group of patients into their subgroup of patients into their big research, and they can amend their research easily. So consider that. but consider also that they will help you only if your proposal is useful to them. So by adding a group of patients, let's say an adult congenital patients that are adding to their group of research group, that might be helpful for them. But if you go in with a new idea, I think in my experience, it's difficult to implement because they don't have the time to think about it, they don't have the money to help you, and you become more a burden than a help. And then actually, as I said, think laterally, other university department, renal, inflammatory, neuro, psychology. There is a lot of out there actually where our specialty can be interested in. I have linked, for example, with the biology group of John Moores and the sports science group and the biotechnologies of the University of Liverpool, and we had actually some projects through that way. My experience in working with non-medical school university is that they like to work with clinicians because they're not used to, and they find us quite interesting to work with. They still have their agenda, but they are more flexible, and sometimes they're not as stuck as the full medical school universities. And also, they are more keen to have a different point of view and get involved in new projects. So identify as well readers and associate professors that might want to have a different point of view into their career progression, and they might help you in that way. And once you have access into a university, you can access internal stream of funds, which can obviously be quite useful, in particular because you can actually have help from applicants for higher degrees like MD, PhDs, or MPhil students that want to be involved in research from a non-medical school background. So you will be working alongside biologists mainly, but also geneticists and psychologists and so on, and that's it. So this is actually just what we have been doing at Oldeham in the last 7-10 years. We had some retrospective studies. We had nice papers on early extubation, and about 50% of our non-neonatal surgery are extubated on table nowadays. We had nice reviews about apoplastic aortic repair, VSD repair with a new technique of detachment of the tricuspid valve, and so on. And then we were involved into prospective studies, which we are gonna briefly show you. Now, the things that I have learned that are different, and you can actually, and I want to pass it on because it's something that is becoming more and more relevant in our specialty, is not only looking at quantitative methods like the one that I've been telling you so far, but also the qualitative methods that gives a different way of approaching some of the problems that we have. So at the moment at Oldeham, we have two main things. There is a quantitative research that investigates how to reduce disability following congenital heart surgery, and basically you have your data, you sort it out in different colors, and then you stack them up in different bars, and then you present and you say, yes, we have been putting up 100 of the red bricks, and they are equal of the hundreds of the yellow bricks, and so on. So that is how quantitative research work. Basically you work with numbers. Now, the qualitative research instead, it started around 7 years ago, because actually at John Moores there is a big emphasis on that, especially on the cardiac group of patients. And we are investigating the social aspect of congenital heart surgery. And that actually really, with the same bricks, you can explain the same concept, but with a story. and it gives you a different perspective altogether. Now, starting with what we have been doing at Old Hay, and I will go a little bit quick with that because I don't want to celebrate what we've been doing, but just to give you an example. So Lucy Finnegan was my first PhD student, and she now works in Oxford and with the cardiovascular group there, and she's finished her PhD. And we recruited her from a biological science group, and we wanted to be involved into cerebral blood flow velocity during neonatal work undergoing aortic arch surgery. And in order to perform that operation, we need to drop the temperature of the patient down. And we realized actually there were some surgeons dropping the temperature down to 20 degrees and some others, like myself, stopping at 25 degrees. And we wanted to know actually if there was any difference in the cerebral blood flow velocity in this group of patients. So this is actually basically what's happened during an arch repair that you need to enlarge. You need to use the heart-lung machine to cool the patients down. And sometimes you cool down to 18, 20 degrees and to ensure cerebral protection. And now these grafts, you will see throughout your career many times these grafts, and that basically shows the oxygen consumption, the one on the left, the oxygen consumption at different temperature, at different flow rate. And that means actually that you can reduce the flow or your bypass machine as more temperature drop you achieve. And but then actually we also during the phase of low perfusion, we also perfuse the brain selectively for what is called actually antegrade selective cerebral perfusion. So we stick a cannula into the innominate artery, and once we do the operation, we selectively perfuse the brain at a specific pressure and a specific flow. And that means actually that we can check with an ultrasound the cerebral blood flow measured at the middle cerebral artery. And that gives you basically a velocity, which is a measurement that depends on the size of the vessel and of the flow that you give a specific temperature. So what we have done, we measured the transfrontanelar measurement of middle cerebral artery blood velocity at all these timelines. So before the operation, on bypass, while dropping the temperature, while we were stopping the temperature, and then during the cerebral perfusion, and then during the rewarming phase. We also measure the NIRS, which are like the saturations of the brain, and then analysis of the PO2, PCO2, and lactate. So what we've seen actually, now this is a busy slide, but just going very quickly actually, basically we have two groups of patients, one at 20 degrees and one at 25 degrees. And this is a cerebral blood flow measured at all the timeline that we have just said. As you can see, there wasn't statistical significant difference in the cerebral blood flow in the middle cerebral artery throughout the operation between the two groups of patients. And that was confirmed by the NIRS, which was more or less the same throughout the operation. So we concluded actually that at 25 degrees it's a safe apothermic level, allowing adequate cerebral blood flow and distribution throughout the brain. And dropping the temperature to 20 degrees might give a safer margin for longer procedure without compromising the cerebral blood flow and the distribution. So that is something that Lucy has done really as a biomedical biology student, and has taken on as her PhD. Now, what she did actually, furthermore, she wanted to check actually the cerebral blood flow during the ECMO patients. Now, very briefly, ECMO is used when either the heart or the lungs or both organs need recovery, and can actually be achieved by a peripheral cannulation, usually in the neck, or in the central cannulation after cardiac surgery. So the aim was to measure the cerebral blood flow in the same way that has been explained before during the ECMO treatment, during the weaning phase. So without going in too much details, what we have seen is that measuring the mean cerebral blood flow velocity in two groups of patients, the one that was successfully weaned off ECMO and the one who didn't, we found actually that cerebral blood flow velocity was lower in the patient who failed the wean of ECMO, while the NIRS could not detect that. So that was an important piece of information that gave us to conclude that the cerebral blood flow may indicate successful weaning during a VA ECMO phase. So that was actually a further study that stemmed out from her research. Now, I will skip, for the interest of time, some of these other that research that we have been doing, and I will go actually on what we have been doing on the qualitative side. And now this was actually the first study, and I think actually Tim, in fact, was involved in that, because the idea actually was to have an understanding of risk of cardiac surgery. And Tim has done actually the background of the Bristol inquiry and all the scrutiny that we are going through. And we want really to know what is an understanding of the parents. What did they understand about risk of surgery? So you go and they say you have 20% risk that your child might die as a result of the operation, and what really is it's important for the parents. And then we ask actually all the surgeons in the UK the same question, and we were able to publish actually the 3 papers actually where for the first time actually where we had a qualitative understanding of what the parents really understand with risk and how the risk changes throughout the timeline of their child being operated and after the recovery, or if the child has a complication, how the perception changes. So another study that we have done was to investigate patients after a Fontan operation. What were the barriers of activity after the Fontan operation for a single ventricle? And that actually gave us really very interesting results, especially about the composition of the family and the presence of siblings within the family. And these are actually aspects that are probably not well studied actually in our specialty, but they become more and more relevant in order to not only give a patient a quality of surgery, but the quality of life after surgery. And we also investigated how psychologically we teamed up with the psychologist, and we recognized that some of the adolescents and adults operated with congenital heart disease have got a higher incidence of depression, and we wanted to have a look which are the interventions that we can actually put in place in order to help them going through that phase. And so these are the ongoing collaborations that at the moment it's happening within all the HAY. So we collaborate with JMU, with the Department of Sport and exercise science, the cardiovascular physiology, the genetics department, and the Institute of Health and Research, mainly with a qualitative studies that I've just depicted. We obviously welcome the foundation of the Liverpool Centre for Cardiovascular Studies with the University of Liverpool and the Department of Cardiology, the appointment of a professor of cardiology, and in fact actually was have been headhunted from Birmingham adult cardiology department, and that actually has made a big difference in the region, being able to do research. We also collaborate with the Liverpool Aortic Biomechanics and Biochemistry Group, and we collaborate with the ACHSA database. Now, just a little word, and then I finish here about the ACHSA database. Now, the European Congenital Heart Surgery Association, about more than 20 years ago, got the funds to start the first European congenital heart surgery database. Now, after more than 20 years, there are more than 35,000 procedures stored into the database. And that is a possibility for everyone to run large epidemiological and follow-up studies. I'm a part of the ACHSA, and in fact, I'm the general secretary of it. So if any one of you want to get involved with that, please get in contact with me, because we need young people who want to take on research from the database, and it's for free and it's all funded, and it's a fantastic opportunity to learn how to write projects from large database. So in essence, and I'll stop here because I think I've overdone my talk. If you want to be interested in research, just do it. Don't be fussy and don't be shy. So knock on doors of people, think laterally and look around you. Prepare to give up some of your time, especially the free time that you have, and be honest with your objective. Don't be too smart. But if you want to think big, do it, but small steps at a time. And the reality is that even if you think that your research pathway is going to be a nice walk in the park, the reality is that it's going to be bumpy, it's going to be quite difficult. But if you persist, you will get there. And if you will get if you will see people who want to give you some help, please accept help, because you will need it. And I thank you for your time and your attention.
Thank you very much, Prof. Lotto. It was a brilliant talk to hear about the research side as well, and to understand the career options you have as an academic surgeon, which is something that we don't have talked about a lot in a lot of these sessions. Would it be all right if I could ask Mr. Jones if you're able to come back as well?
Yep, there we go.
Amazing. So we have a few different questions, and if you're happy to, I can just crack on. I'll put them up on the screen. I think it should be visible as well. So this is a question from Tiag. Can I ask how to overcome the struggles of finding a mentor in congenital cardiac surgery? I'm from South Africa, and we only have 2 consultants in our province, and I'm often put down for being a student interested in the specialty at a young stage and told that I should have no reason for this aspiration. I want to be a student who publishes and goes to theatre, but is seen as overly ambitious and unnecessary. I'd like to hear your thoughts about this.
Okay, but yeah, interesting one. So a couple of things. The important thing is to just go and get involved. Don't be put off by what people may say to you. Oh, you know, you're too keen, or I don't know why you want to get involved. Just be there. Be there. And as Attilio said, if there are projects, get involved in a project, be useful to the individuals who are there. And you'll find then that you'll be taken on board. The other way of doing it, of course, is to go and do an elective period of study somewhere. So go to another unit, potentially in your country, or if you're able to, out of your country, and spend an elective period, anything from sort of 2 to 6 weeks, whatever you can, with a unit. And then you'll build up relationships with surgeons in that unit, and they'll often be very good mentors for you as well. I know a lot of the units in South Africa, so I don't know if you want to contact me afterwards and then just see if I know any local individuals might be able to put you in touch with.
Thank you. And Prof. Lotto, do you have any?
Yes, I mean, it's a very interesting question. Without entering into the specific topic of South Africa, and I know a little bit of South Africa, not only because my wife is from Cape Town, and I know, and I was working with Tim. I was a senior registrar when Tim was a junior consultant. And one of the guy there was a South African guy, Andre Brooks, and I think we share the friendship with him. And but one of my friends actually is Darshan Reddy in Durban. Without getting into that, I mean, I want to make a comment actually about the mentorship, you know, and looking back at what I had two types of mentors. You need someone who takes an interest in you. So you need someone who is able to sit for half an hour and understand who you are, and give you some good suggestions. So that doesn't mean actually that it tells you how to do an operation, but it's able to direct you a little bit, because at times I'm sure that everyone will get lost and you don't know where to look at. And having someone who is senior enough, you can, and nowadays it's even easier than what happened a few years back. You know, you can write a quick email, you can have a quick phone call or a text to someone who is able to direct you a little bit and get out that depression that sometimes you will have. And then obviously, you know, you need someone who is teaching you the job, and that is a practical part of it, you know, so that is going to theater and spending time. It is difficult, and I think actually that no one is born as a mentor, but you can become a mentor. You can show interest for juniors at different level. I'm learning how to train junior people after I've learned how to train more senior people, because when I was a consultant in Leicester, then I had a junior consultant, and it happens actually that I have to take him through some operation, and that it's easy, but the complex stuff for me is to teach someone junior. So you need also to understand actually that the complexity of mentoring and teaching from both sides. But there is no doubt that you need a little bit of luck, but you can actually be, you can find your own luck. That's what I'm trying to say.
Interesting. We also have a question. How do I find out if I have the technical skills to become a good congenital cardiac surgeon? I think it's a hard question to
Okay,
answer.
shall I kick off with that? One of the great things about congenital cardiac surgery is you can do the surgery at different levels, and you see this in practice. There are some people who will end up, they'll operate and they'll be operating, they'll do all the straightforward stuff, the middle complexity work, and you'll find that the really high level complexity work, not everyone does, and not everyone has to do it. And so you only really find out at what level you will go through in congenital cardiac surgery once you start doing congenital cardiac surgery. The bottom line is really you need to be at a place with adult cardiac surgery where you can comfortably do a straightforward operation with supervision. And you've done a number of them. So what we tend to say is ballpark figure, you know, if you've done 100 adult operations such as coronary artery surgery, aortic valve replacements, things like that, and you can do them comfortably. You don't feel stressed if it's a straightforward operation with your trainer standing opposite you. Then you normally have got the technical skills then to be able to consider going into congenital cardiac surgery. And then when you go into congenital cardiac surgery, it's only really as you develop the skill set that you'll find out at what level you'll end up doing operations. And most surgeons under a mentorship can get to do the full range of surgery. Otherwise, you wouldn't have got to the level you're at through the cardiothoracic surgical training program. And then if you wind it one step backwards, most people who don't have the technical skills to be a surgeon aren't comfortable doing surgery, and they tend not to follow surgical careers. If you see what I mean? I get asked this question a lot, and it's a self-selecting thing that people who enjoy surgery and have an actual attitude and adept to doing operations usually end up being self-selected into the training pathways, that they're the ones who go for it. Occasionally, though, we do have trainees who don't progress and reach the competencies technically, and we'll put in a lot of support for them. But it's very, very unusual that we've ever had to remove a trainee from one of our cardiothoracic programs because they lack technical skills. And in fact, if you look at all surgical specialties, we probably have got the lowest dropout rate and the lowest removal of trainees from training programs because they're not reaching competencies or progressing. So no immediate answer to that, but I hope I've sort of touched on some areas you might find useful.
Thank you. And Prof. Lotto?
Yeah, it's a very interesting question, because I was asking myself actually, 25 years ago, have I got two left hands or what? And I think actually you need to satisfy that question. You don't bury your head under the sand. You really need to answer that question to yourself. Have I got good hands to be able to do other cardiac surgery, first of all? And I think I completely agree with Tim, actually, done about 100 cases of mixture between valves and grafts, in particular grafts, I think. I think if you are a competent graft surgeon, you can, under direction, be able to do an arterial switch with not much troubles. But if you struggle, and I can tell you actually that I agree with Tim actually, I haven't seen people dropping out cardiothoracic, but I've seen people moving from cardiac to thoracic because of the struggle that they had in the most refined surgery, especially the graft surgery. So I think actually doing grafts you don't need to do 1,000, you just need to know that you're doing grafts and you got good hand for that. And the second thing, actually, you need again to be lucky to find out someone who tells you that you're not good enough, because that is one of the problems that I witnessed during my training career, that some of my colleagues were not told, and they became frustrated surgeons, and that is the worst thing that you can possibly have. And there is nothing better to be good at something that you get satisfaction from that, but there is nothing worse than not be good at something that you like, to get the frustration, and that will end up with patients' problem. So again, actually, luck plays a role actually in be able to find someone, if you're not good, who will tell you, consider another career, because you're going to find something that you are good at and you enjoy doing.
And we have a couple of more questions if you both still have some time to answer them.
Yes, please.
Would you say that as a congenital cardiac surgeon, your typical week is harder, longer, or more stressful than your adult cardiac counterpart? And also, I think this might be directed a bit more at Prof. Lotto, but what percentage of your week do you split towards research as well?
So I wanted just to make a comment actually here, because, things have changed and there are a lot of myths that are still circulating, in particular among the adult cardiac surgeons and among the thoracic cardiac surgeons, and they usually are the one who discourage the trainees to get into a career in congenital, because 20 years ago or 30 years ago, the life of a congenital heart surgeon was miserable. Usually there were one or two surgeons in a busy department, and I'm sure that team can witness that in Birmingham, working really hard. I have great respect for those pioneers, because I don't know how they could have done arterial switch operations, 30 years ago. I mean, it was a misery in their life, I'm sure. But now things are not anymore like that. You have more colleagues around. It's a teamwork. There is a better work-life balance that you used in the past. And I think actually, as Tim alluded, actually, there are very good rewarding, and sometimes you get battered by the bad case that happens. But overall, I think we all enjoy fully what we do. So it's a great career, and hasn't got any more that that practical thing that you stay in hospital all day, Saturday, Sunday, and nights. You know what I mean? The work-life balance is there, because we recognize that a lot of surgeons in the past burned out, and that is not what we want. For dividing the week, actually, it's again, actually, it's a little bit of jiggling few balls, actually, at the same time. And I'm sure that teams with his involvement with the SAC and and so on, actually, has to jiggle more balls than me. And but you get used to that, and you use your time efficiently, and that's the trick, actually, is to use the time efficiently and not wasting time. Yeah.
And Mr. Jones, we have a question. As a young cardiac surgeon, what steps should I take from abroad? What steps should I take to continue my career in the UK?
Okay, so if you are not in the UK now, then you'll need to start an application for GMC registration, and that can take quite a period of time. You also have to go through an English speaking assessment and various things as part of that application. Don't underestimate the time it takes. So you can start doing that application even before you've actually got a job. So and if you do then apply for jobs, there are various fellows jobs and other posts, that standalone posts that'll come up on the BMJ careers section or NHS job section. You look for those jobs. If you've already got your GMC registration, and you can just apply directly to the GMC for that, it puts you in a much better position to get one of those jobs, because people tend to go out for the job advert when they need the person. And if you apply for the job advert and say, but I haven't got GMC registration, we all know that could potentially take up to a year for you to get. So get your GMC registration done, then apply for a job and get to the UK. If you're already in the UK and you've got a job, then you can go through a series of standalone appointments across any units, across all units, to undertake training. Now that training will be informal training. It won't be in training approved posts. So if you're starting off in your career in the UK, there's two options. You can try and do it through standalone posts, and then when you finish a period of training, you have to apply through what used to be called the CSER route, the Article 14 route. It's now called the portfolio route. And that is where you have to show that you've got the knowledge, skills, and experience comparable with a day one consultant trained in the UK. And that's an arduous process to go through. It involves a submission of all your training information and details and data and everything you've done over your time. So that's one route. The other route is when you come into the UK, and if you are spending a period of time in jobs, is to apply for a national training program number, which is the scheme I outlined, and the National Training Programme number takes you through and automatically puts you on the specialist register on completion, so you don't have to go through the Article 14 CSER portfolio route. Okay.
Perfect, thank you. And we have another question. Are there any places where medical students can intercalate or do higher degrees and carry out research within cardiothoracics at any of the institutions? It says apart from Bristol.
Yeah, University of Birmingham. We've got a large ongoing relationship with the University of Birmingham. The actual department, our congenital cardiac surgical department, has through intercalated anatomy BScs that all rotate through the congenital department, and you can elect to do your intercalated project with us, and we've got a very good track record of that. Plus also we've now started an MSc as well as other interacting at other ways within the undergraduate program. So if you're looking to do an intercalated BSc or an MSc now, University of Birmingham does it. A number of the other universities do as well. There also is, through the Royal College of Surgeons of Edinburgh, there's the medical student sponsorship and medical student placement scheme where you can apply, and there are about half a dozen units around the UK that take on medical students for a couple of weeks at a period of time. That's also a good way to build up a rapport and relationship with a unit and mentors in the unit as a medical student. The Society for Cardiothoracic Surgeons, the UK, does their standalone days where they have sort of medical student interest days. Look out for those from the society websites. And that's where basically there'll be a day they rotate around the UK to different medical schools or different universities, and we tend to put on a one day looking at some aspects of cardiothoracic surgery as well as the generality and expansion of what we've really gone through today. And then similarly, the society is also developing a medical student mentorship and sponsorship program where we're trying to put medical students with established clinicians as sort of to help with mentorship and training. So there's lots of different options out there. But to your first question, yeah, University of Birmingham definitely has, and I think the other universities do as well. Attilio, you might be able to help a bit more with that.
Yeah, absolutely. We have as well, actually, with the University of Liverpool. We have regularly in summertime. We usually have, all the summer busy with medical students coming for 2, 3, 4 weeks. Actually, in fact, I got a medical student actually that graduated, and she then continued to do some research with us and just get involved in things. So it's a very good way actually to get in contact with groups and yeah, absolutely, and with people.
I mean, I can echo the University of Birmingham side because I am starting there this year on the MSc program.
Good.
And we have another question. So, as a student going into, for example, an observership as compared to an elective, which might often be the case, what advice would you have to ensure that you can gain the best out of this experience?
Okay, now if that's put, so there's a couple of ways. There's a few ways of doing that. A lot of the medical students have student selected placements, or they're called different things in different medical schools. But basically, usually in part of your 4th or 5th year, you can undertake a 1 to 2 week period where you can elect to go into a hospital of your choice. Now, for those placements, there's normally a sort of a prerequisite by your university of things you've got to do, or you've got to be there a certain amount of time, or check in, check out. The other option is to actually do an elective period of study, and the elective period of study is usually a longer period, often 4, 6 weeks or so, and that can be done in the UK or overseas. If you're doing an elective period of study overseas, then obviously what I'd say to you is, yeah, you want to get involved with the department, but also if you are going overseas, it's an important development for yourself to have time and do some other stuff other than just spend all day in the hospital. That's for sort of your long period of elective study. But any period of study that you do or observership, get involved, turn up. be there, use all the opportunities, be opportunistic, because if things are happening, then go and see them, get involved, watch what's happening, be around, follow up the patients. If you go starting off, then the thing to do is to talk to some of often the surgical trainees are great people because they'll be very keen to support you and help you, and they'll tell you exactly what's going on a sort of throughout the day on a day-to-day basis. And the thing to do is to sort of ask them to is there an interesting patient, go and meet the family, meet the patient beforehand, watch them go into theatre, see the operation, take them through to ITU, follow them up in ITU and follow them back up on the ward. You get a good feel for what's going on then. Ask if there are any projects that you can get involved in. Ask, how can you get involved? How can you develop your understanding in congenital cardiac surgery? All those things. If you turn up and you're keen and enthusiastic, people will normally be keen and enthusiastic to have you. If you turn up on the first day and we don't see you again, apart from at the end when you need your paperwork signing, you probably won't get so much support. And if you turn up and sit in the corner of theatres on your phone, I can guarantee you're probably going to get very little out of it. And people, it's a busy, every day's busy, and you'll just get bypassed.
And Prof. Lotto, do you have any?
No, I agree completely. Actually, you just need to show your interest, actually, and consider that, as I was told, intensive care is cardiac intensive care is 24/7 place, so even if there is no theater going on, you can always go and learn about, physiology, see the patients and everything, the beauty of this specialty is that you are not just relegated into theater. So there are a discussion of cases which are really very interesting at the MDT, learning actually the physiology of the patients, the morphology. In Birmingham they have a fantastic library of heart samples with Adrian Crucian. I locked myself with Bob Anderson for 2 weeks at Great Ormond Street before taking up the specialty, because I was interested in morphology. These are all things that you can do, and it will stay there for the rest of your life.
Yeah, but I see the questions about also some time in Malta. If you're going elective to Malta, get in the hospital, but also see some of Malta, because your medical student time and your training time are a fraction of what your career. You're going to do a 40-year career, and once you leave medical school and once you leave these opportunities and start on your career path, there's not a lot of time. You're on a program unless you put in a specific pause or take some time out. And remember, the best surgeons and doctors usually come from the most rounded people, and you become the most rounded people by making use and taking up all of life's experiences, not just those offered to you in the operating room. So if you're going to Malta, get stuck in with the hospital, but